Which button? There we go. Good afternoon for those who are on the Zoom. My name is Gary Merchant, Representative Gary Merchant. I'm the chair of the Prescription Drug Affordability Board. Today is August 28th. Boy, am I in September. 2 o'clock in the afternoon. I'm calling the meeting to order. First on the agenda is introductions, establishing a quorum. Again, my name is Representative Gary Merchant. I chair the Prescription Drug Affordability Board, and I'll move it over to my colleague across the table.
Bob Woodward, alternative representative.
Jason Hazes, Director of Health Economics from the Insurance Department, appointed by the governor.
Awesome. And on Zoom?
Representative Jim Murphy, representing Hanover, Lyman, Grafton 12, and a member of the committee or the board.
Thank you.
For the time being.
For the time being. Okay. For establishing a quorum, will elevate Dr. Hazes as a member for today, and also Dr. Woodward as a member for today to establish the quorum. In regards to agenda review, is there anything on the agenda that people would like to add, move, change? I have one, but does anybody else would like to go before I? I would like to move the accounting update, which is Rob Berry, above earlier into the meeting under the MOU update. If there's no objections, I'll move that. Make a motion. And then as far as the board member update, I did receive a letter. It's dated, actually. It goes back to February 9th. Senator Bradley, who's the president of the Senate, has assigned Senator Abbas as a full member. We still have Dr. Sherman as a full member until I think November. Senator Carson has been assigned as an alternate, and Senator Rosenwell has been assigned as an alternate. Senator Sherman's term expires on November 1st, 2023, and Senator Abbas's term will expire on November 1st, 2024. And I'll put this into the recorder secretary so you have it. And I believe we have also Representative Murphy, you're I think coming off the board sometime in November?
September, actually.
September, okay. Okay. Can I have a motion to approve the minutes from the June meeting?
I'll approve it.
Second.
Okay. So all those, Dr. Woodward made the motion, Dr. Hazes seconded it. All those in favor say aye.
Aye.
Aye. Any opposed? The ayes have it. Motion is approved. Minutes are approved. Mr. Berry, front and center, hot seat.
All right. Well, good afternoon, everybody. I hope your summer has been fun and exciting. I know mine has been. So in the last, since we last met, we've had 3 big events happen, which I'll go over now. So we have an MOU that is now fully executed and in effect. It was fully executed as of June 23rd. We had consulted with the Department of Administrative Services about the need to go to Governor and Council for approval. At that point in time, they said since our MOU did not actually have any monetary exchange at that current point in time, we did not need to go through GNC. But with that being said, we have a term currently for 2 years with 1-year extensions. We're likely going to have to revisit the MOU before that 2-year term expires, so we can go over when the cost allocation actually does take effect. But for now, we do have an MOU that is in effect, which I thought was very exciting news. So as we get closer to determining what the cost allocation basis is going to be, we'll have to talk about that. We also have an accounting unit in place for the board to utilize here within the department. So that came about as a result of the passage of HB2 and its effective date. So now the board is able to accept funds and expend funds, which was a big news. And then one thing that's not on the agenda, which I thought we want to talk about here, is the executive director position was posted for receiving applications late last week. So I'm listed as the hiring manager for that. What that means is I'll receive the applications once they come in, but from there I will be forwarding them on to the chair for the board's consideration. The unfortunate thing is we have not gotten any applications as of yet, but we are working on that. And I do understand from HR that the position was also posted in addition to our NewHampshire.gov website and our internal New Hampshire First system for internal candidates that Indeed and LinkedIn are now have the posting as well. So hopefully we'll start getting some candidates coming in, but I check daily to see if we get anything. So far we haven't, but.
Are you looking for other venues for distributing the?
I'm happy to talk to HR about it if you have another idea that might elicit some more responses.
So the university kind of issues, health affairs, Journal of Health Economics, they're just a series of places where candidates might have the kind of training and be looking for jobs. I
Sure
don't have anybody up my sleeve, but
no, I think we had somebody up the sleeve. They'd already had their application in. But yeah, if you have any ideas, feel free to send them along. Mail send to HR. I think they said something about.
can I send it to board chair?
Yeah,
You can send it to myself and I'll send it on.
Yeah, whatever works. But yeah, I think HR indicated they were willing to use some other resources if necessary.
Good point. Thank you. Okay, as far as that takes care of the MOU, the executive director, and then as far as the annual report, I think we have an outline in here somewhere. So what I wanted to accomplish today was just going through the outline before we get into actually creating the content of it, that the board members we're all on the same page as far as what should be in the annual report. I know Dr. As is, and also Dr. Woodward have been working a lot with the databases and trying to come up with some data, if you would, in the report itself versus being strictly narrative. But if you could speak with that as I get through it. What we have so far is I'll do the executive summary, go through the table of contents, then we'll go through the task and so forth about the legislature, what was required by the board through the legislative process, then some CMS CHIS data. And at that point in time, I'm thinking number 4, Dr. Wood, would you want to kind of give us a brief understanding of what you're trying to accomplish in your part of the annual report?
So number 4 is basically looking at the prescription expenditures and the overall healthcare expenditure picture in the nation. And number 5 is the same kind of statistics using the state data. 4.3 and 4.4 are using the state data, not just national data, that are already published. I have that data and have played around with it. I'm quite confident that I can put something together with charts and a summary of what the implications are, how the story for the state differs from the story of the nation. The main bullet point 5 here is using the state CHIS, New Hampshire CHIS data to generate conclusion about expenditures, patient dose, and volume. There should be a comment between dose and volume, or dose volume, and prices per dose, kind of information. Looking overall, then looking at the 50 most expensive drugs. This pretty much follows the legislative requirement. And then 3, looking at the greatest expenditure increases between 2018 and 22. That data I have pretty well, and I think I'm comfortable with that. On main 5, subsection 4, one of the things we noticed in last report was that there were some drug generic classifications where the expenditure decreased from 2018 to 2022. And I have asked for help getting the tables for those to be able to tell a story that's as complete as possible with the current data. I have to say that after a period of what I consider to be really great responsiveness by HHS to data requests last fall and spring, I really felt quite responsive. The request for the greatest decreases has been not replied to yet. And that's a little bit disappointing. So whether I can get that done depends a lot on whether I get the data. If I don't get the data, there's nothing I can say. So that's my bullet point 4 and 5.
Thank you for that, Dr. Wood. And then I think also in number 6, we talked, when we talked about this way back when, actually, there are 2 buckets of drug cost. One is the bucket, the pharmacy benefit side of the equation, but also the medical benefit side. There's also drug cost on the medical benefit side. So right now, the way I understand it, you're focusing your attention on the pharmacy benefit side, which is like NDC numbers and so forth, et cetera, looking at it in that arena. And Dr. Aziz is going to be looking at the medical benefit side and trying to determine within it, help guide us what may be going on in that bucket. So if you want to talk to us a little bit about that bucket, about the medical benefit and what drug costs look like under that piece of it.
Thank you, Mr. Chair. I appreciate it. Thank you. That's interesting. The decreases, I think, tell a compelling story. And so I had a question about that, if I could take one step back. Are we narrowing our purview to the Medicaid data? And I thought we were looking at all the CHIS claims data, including commercial, but not in this report?
Not in this report.
Okay.
Because this report, we're trying to go looking at it, is based upon what the statutory requirements are, is the public payers. And the predominant one is going to be the quote Medicaid.
Oh, okay.
For this time.
Okay. So with regards, I did some exploratory descriptive analyses looking at some of the drug spend in the medical benefit, found some interesting anomalies. One of which was across a continuum of a specific costly biologic and its biosimilars. I saw mixed provider billing practices looking at about 6,000 claims in 2022 in the medical benefit side, but about a quarter of that amount, 1,900 claims with NDC numbers on the prescription drug side. So I had not expected to see that, and I kind of wanted to bring it up to the board to talk about how we handle that. I think some of these newer drugs, there may not be standard billing approaches to billing, and I think that may be reflected in that one analysis. That's narrowed down to one drug in its inherent biosimilars, but nonetheless, it was a significant proportion of total claims activity had existed in the medical and then the pharmacy data. So we wanted to tell a story about, how these biosimilars upon entering the market may have a good exert a downward pressure on prices to the brand name biologic that it competes against. And so I'm not sure how that affects it, but I think we should talk about whether we use that drug infliximab, Remicade as the example. We'll try to look at another drug that is more standardly billed only in the medical benefit.
So in the database, when there's an NDC number, is there also a J code?
No, that's what we're, Morgan Harris is here. She's our director of healthcare analytics, and I welcome her. We're doing sensitivity analyses to see if they happen concomitantly, and thus far, I have yet to see a medical claim with a HCPCS J code and an NDC number in it. So those examples that I'm referring to don't qualify as that. So which means that we can infer that they occur in the medical claims data. And that they're the pharmacy claims data, and that they're billed maybe picked up at a pharmacy. I wasn't sure how the board wanted to perceive that, but being that they're new and really just representative 2022 billing activity, you know, it seems to reflect anomalies at the billing provider level.
Is there a way to find out? Because one of the things that's happening has been some market movement here of the drug, instead of being purchased by the clinician and then administered by the clinician and billed for the insurance company. What is happening is that the drug is coming from a pharmacy into the provider. And then the provider shouldn't really be billing for the drug, they bill for the administration of it, but they're billing for the drug. That's kind of interesting, is how are they accessing the drug? Is a way to find out.
The fact that the claim has an NDC number suggests that it's being picked up at a pharmacy, at an individual pharmacy, not at a hospital-based pharmacy.
Is there a way to understand where the payment's going for that drug? Who's receiving it?
Not necessarily through the pathway that I've been using, but it deserves more explanation. So we're working on that currently. And I know that we have a little bit of time to prepare that analysis. So I thought it worthwhile to bring that up and maybe look at other parts of the claim for those examples, and or maybe look at another biologic that has biosimilar competition that may be less prone to that practice.
So is there a way, if I understand it correctly, in the database, we're going to use the drug Remicade, Fluximab. Is there a way to understand, is there cost differential between the NDC number versus the J code? Because what I'm trying to get to, if the NDC number, just using numbers here, is being charged or billed out at $1,000, but the J code equivalent to it is $800, then why is there the difference?
So yeah, we'll do a sensitivity analysis to see if there's a cost differential under those two conditions, and that would be a good first step towards gaining more insight into this new and frankly unusual market.
Following up, this is a supplement to the question that you've been asking, which is, can you distinguish between brand name and generics in the coding you have, to be able to distinguish whether it's the brand names that is being charged differently or whether there's more use of the generic?
And that was our first step, and I think Representative Merchant guided a nice analytic framework for that. And these large molecule biologics, they don't have generics, they have what are called biosimilars.
Gotcha, understand.
And interestingly, the cost savings for biosimilars is not nearly as robust as the small molecule and their generic counterparts. Nonetheless, we have seen what we expected to see was significant downward price pressure with just the early onset of these biosimilars for Remicade. So, but it's still unclear whether that may be an artifact of also other ancillary billing practices that involve clinics providing that service. So I'll explore that to see how that's affecting that lower price for the biosimilars, and report back on that next month, and then have a more complete, cohesive, and summary report for our next meeting.
Would be helpful, because we talked about that before. The specialty drugs, the ones a lot of times in the medical benefit side, are now approaching over 50% of the overall drug cost. So it's going to be an important market for us to begin to understand what's going on within that market. So any kind of data you can share with us to help us understand it, and then once we understand it, what can we do to try to minimize the cost factors? That'd be helpful. Thank you.
Interesting stuff.
Yeah, it's good stuff. And then as far as the summary goes, what I'll do is work on some of the recommendations. We talked about this before. We have a tendency sometimes to look strictly at the cost of the drug itself for the manufacturer, the list price versus a lot of times is not actually overall cost. Is looking at it and saying, is there ways for us to collectively look at opportunities to reduce costs because we reduce it because of the issue of substitutions, whether it's the small molecule, generics, or biosimilars. Looking at, again, today's topic is drug waste. There's a way for us to look at the reimbursement model and saying there's a way for us to use reimbursement to help move the market in one direction to reduce the overall cost burden. So thank you. This is all good stuff. We're making progress. Now, I do want to add something to the agenda because, as we talked about before, and I was neglectful, is the redundancy in House Bill 2. There is a requirement for exploring redundancy between this board and specifically the insurance department. So later on, if we can have an update, Doctor, that'd be helpful. I don't think I see is he on the thing?
So I heard that you forwarded the invite to him, but we actually need to give him a dedicated invite. So I sent him one this morning or this afternoon. Although I don't think that he got it. Or no. So he is right now an attendee who is not able to share his screen.
Can you bump him up to
Yeah, you should be able to.
you should be able to promote it.
Up to the top.
There he is. Okay. He's there. Mr. Felt, how you doing? You're on mute, sir.
Now it should be okay.
Oh, there you go.
There you go. How are you, Gabby?
I'm doing fine, thank you. So I'd like to know if you want to come down to join us here in the hot seat.
It's really hot.
Yeah, it is. Well, it's going to warm it up. We've got a crank right here for you. So I just wanted to let you know these two gentlemen I've known for quite a long time, and I asked them to give a presentation here today. Mark Stelt's an entrepreneur extraordinaire. He's done many things in his career and so forth. We crossed paths probably about 10 years ago, maybe longer than that. I remember I had probably a little more black hair back then and so forth.
Yeah, I didn't have as much gray either.
Yeah. But Mark's a wealth of knowledge as far as the pharmacy distribution and things of that nature. So I've asked him to come along with Jay, Mr. Gupta, to present with us. And Jay comes to us from Harbor Care, which was Harbor Community or Harbor Homes and so forth. He's been involved with 340B and been involved a lot with the pharmacy as far as that process. But what caught my attention in the story was what they were able to do in their respective arenas to find ways to reduce the drug waste and working with providers and working with insurance companies to accomplish that. So that's my introduction to these two gentlemen. So I'll turn it over to both of you, whoever wants to drive the ship. Thanks.
Hello, everybody. My name is Jay Gupta. I'm the Director of Pharmacy and Integrated Health at Harbor Care. And my colleague, Mark Stelz, so he will be talking about the second part of the presentation with a different category of medications. So Harbor Care used to be called Harbor Homes. We are in Nashua, New Hampshire. Our mission is to work with people experiencing homelessness. So really vulnerable population out there. We are patient-centered medical home. That means we provide, very integrated services.
Can you put it onto a slideshow up on the top? The may help to filter it, and then also can we minimize on? There you go. Awesome, thank you. I want to be sure to give you all the attention you deserve.
Great, thank you. So housing was the first program. That's why it was called Harbor Homes, but then we added healthcare, veteran services, home care, HIV/AIDS services. So, trying to provide all services related to healthcare, including the social determinants of health. So when I met our CEO in the organization about 8 years back, he had a pain point. We had a lot of people experiencing homelessness who also had mental health conditions or using substances. He said when people are given prescriptions by our providers, they go to the pharmacy with a promise they will get the medicine. But in many cases, people went to the pharmacy and the drug needed a prior authorization, and they were told, come back in a couple of days. So many of you might have heard the stories or might know people who are in recovery right now, that it takes a lot of effort on part of the person who is dealing with substance use disorder to get into recovery. So they get all their energy and go to the provider, and now they want to be in recovery. They get a prescription for, say, Suboxone. They go to the pharmacy, they're told, come back a couple of days later. They can get irritated, they can be upset, or they get angry. They come back in parking lot, shoot heroin. And that was the time when we had thousands of people dying every year in this country, maybe tens of thousands of people. So opioid crisis, that was kind of the beginning of the crisis at that time. So his goal was, like, he did not tell me we have to make money, we have to be successful financially or not. He just wanted one thing. People leave this building with the medication on hand instead of just saying, you can go to so-and-so box pharmacy, chain pharmacy, and get your prescription. So this is how I started. We, of course, discovered many more barriers to care, not just the prior authorization, but cost of medication, might be high copay for people, PBMs, pharmacy benefit managers insisting that they have to use their pharmacy. So many of these folks, even current my patients, they don't drive. So they cannot really go to Walgreens or CVS or whatever pharmacy is being dictated upon them. Mail order, which I thought was very convenient for a lot of people, I learned that it was a disaster because most of these people were couch surfing or they were living in shelters, but the insurance company will mandate that they're going to mail the prescriptions to them. So they were not receiving the medications or they were not receiving it on time. So several issues related to that. I'm going to talk about those. And some medications people needed for mental health conditions, they were limited distribution. So they had to come from, just 2 or 3 pharmacies in the whole country. So anyway, so I saw those barriers and I started to work to break those barriers to provide medications to the patients. So 2 things I'm going to talk about today related to pharmaceutical waste. And when Gary and I were talking, I mentioned this example, one example, and I started to dig into more data. I realized we spend billions of dollars wasting money on medications. And that waste is caused by the system itself. So we are part of it. So 2 things I'm going to talk about is the white bagging and the brown bagging. So the white bagging happens when the expensive medications, insurance company or the PBM says, we're going to mail it to the provider's office. So how it plays out is sometimes the patient is there and the medication is not there. Sometimes the medication is there and the patient doesn't show up. So the medications get abandoned for whatever reason. It leads to adherence issues because when the patient is ready, medicine is not there. And of course, overall patient clinical outcomes are worse. We also learned that many insurance companies, many of these PBMs will deny the prior authorization or deny the prescription claim, and it needs a PA. But the PBMs will do the trolling. They will call the provider saying, hey, give us the prescription because the patient wants it at our pharmacy, at our specialty pharmacy. And they will call the patient, hey, your doctor sent the prescription to us, so we're going to mail it to you guys.
So, be clear about this. So in essence, the first step is for the denial of the medication by the PA process. But because the process has its own PBM internally, that PBM may not run into the same issue with the prior authorization because there's an incentive to process it through their own pharmacy.
Right. So once they receive the data for the prior authorization, they will send that information to their own PBM by, their own specialty pharmacy, and they will try to capture that prescription from the clinic. So prescription which I was ready to fill in my pharmacy, and we are waiting for the prior authorization, suddenly I learned that prescription is gone. It's being delivered by the specialty pharmacy owned by the PBM, and we are not in the middle anymore. So a couple of years back, our nursing director, she was a new director, so she came to me and she said, Jay, our fridge is full of medication. So can we use your fridge? Because your fridge is bigger than ours. Can I use that? We're like, well, we can't really do that, but why are you ordering all this stuff which you don't need? Or buy a bigger fridge. So I was being, very straightforward. And she was like, oh, I'm not ordering any of this. This is all coming from the mail order pharmacies. And the fridge is jam-packed now. I can't put anything in there. So I went downstairs to the clinic with her, looked at the fridge. We had 2 products, just Vivitrol and Sublocade. Fully packed, no space in the middle. And I pulled them all out. Of course, when I did the whole checkup, half of them were expired. They were mailed and they were not used for over a year or 2. And did a quick math, it was at least $500,000. So $500,000 worth of medication sitting in the fridge, and they cannot be diverted. They cannot be given to anybody else. Sublocade is a controlled medication. We tried with Board of Pharmacy, can we give it to another patient? But federal law says we cannot. And then I realized if this is happening to our clinic, what's happening in the whole state of New Hampshire? What is happening in the whole country? So I did a very quick search. We had only 2 prescribing providers for these 2 medications. In America, last year, we had 50,000 ex-favored prescribers. Okay, now we don't even need ex-favor. So we have at least 50,000 providers. So simple math, multiplying by 25,000, the figure comes out to $12.5 billion. That's the amount of waste just with these 2 products. And I was talking to Gary, like some people can get confused when we talk about billions and trillions. People think it's just a lot of zeros. They don't get the perspective of the amount of waste. So I did a simple math. It's $50 million a day in America wasted on these 2 products. So pharmaceutical companies are making the profit because they're literally selling it. But who is paying for it? We all are paying for it. Medicaid is paying for it. Medicare is paying for it. Our healthcare dollar, the co-pays and deductibles premium going up. So $50 million a day. If we count as 50 states in America, it amounts to $1 million a day just in New Hampshire. And we are talking about only 2 medications. All right, so this is one aspect of mail order pharmacy, which is white bagging. The second part is brown bagging. Brown bagging is when insurance company sends the medication to the patient's home. Now, it is very convenient. I think it's a great idea that patients don't have to move out of their house. People can be more sedentary if they wanted to, and they can just get the drugs at home. But many people receive these medications which they don't even need. The medication has been discontinued, the dose has changed, or whatnot. So very interesting data here. So from the 24th National Take Back Day, which happened a couple of months back, we had 332 tons of medications returned. So I'm going to do a simple math for you guys. This is the documented waste of 8,650 tons of waste in 12 years. So when we say tons of wastage, this is it. This is literally tons. It translates into 19 million pounds in 12 years. I'll continue translating it. It's 4,000 pounds per day, even if we include Sunday. 4,000 pounds.
And this doesn't include the impact on the environment.
Yeah, impact all over the, I can talk about it forever because we both together, we have only 20 minutes, so I'm keeping it very simple.
You get a little more time now because we went through the agenda pretty quick, so.
Okay, so I can talk more,
Yes,
right?
you can.
So if you look at this data, this is from every state, how many locations we had for the take back. So North Dakota, for example, had 0. So this is not comprehensive collection. I think we have about 11 people here and we have about 18 people online. How many people have returned drugs in the National Take Back Day? 3, 4. Good. I can't see online, but out of 11, so we said less than half the people have ever returned. I'll give you another perspective. When we talk about OxyContin 40 milligrams, it's not a 40 milligram tablet. In the waste, it is 130 milligrams. Because to make a tablet, you need to add excipients, right? So the waste will include that excipients also. 130 milligrams. How many tablets will you make from that 400 pounds a day we are wasting? If we translate it to dollar amount, it's definitely more than $100 billion a year. Okay, now this is documented waste. People who are flushing the pills in the toilet, people who are sending it to the regular landfill, that's not included here. So just with these two practices we are doing, by PBMs mandating the mail order pharmacy is causing billions of dollars of loss. And I would say translating that into millions of dollars a day just in New Hampshire.
Just a clarification, impressive numbers. But as you started, your base was the refrigerator.
Mhm.
And you said that about half of that refrigerator was out of date, has expired. So the usefulness of the drugs, your starting point might be, let's say, just 2 times greater than the annual flow every year. What you're hoping to do, I presume, is somehow capture those drugs before they expire. So that would only be the ones that hadn't gone.
So it's a good point. I love this point, but the reality is, we got medications delivered by mail order pharmacy in the fridge when the patient didn't show up.
Yeah.
So patient was supposed to show up, but for whatever reason, patient didn't show up. We wasted that drug. It's going to sit in the fridge until it expires.
My only is your tonnage might be just half as much. It's still an impressive number. But the starting point was stuff that half of which was expired. So as you figure how much stuff you could use in the tons, it might be just half as much as the tons that you've.
Just to, so I understand your question here. Expired medication or non-expired, both got wasted.
Yeah, but one was the previous year and one's this year.
Oh, so they were all probably different dates.
Yeah, right.
They were all different dates. So
half the dates were expired. So if you're looking at the amount of savings that you might incur in 1 year.
I get it. So it may not be annual translation exactly by number. I'm just trying to do an average here. So thank you. Any other question before I move to the next step? Now, of course, I'm not even talking about the people who showed up for their medication. They needed their Vivitrol or Sublocade shot, and the medicine has not arrived for whatever reason. And how many of these people relapsed or died? We don't have that documentation of that.
And just to be clear about this is what's going back to the DEA take back program. What is not included in there, and we probably could find some data on this, the pharmacies themselves send many products that are expired back through for destruction. So those drugs themselves that go back to what our reverse distributors that get it back to manufacturer, hopefully they get some credit for it, but a lot of times because it's expired, even if they get credit for it, it ends up being wasted. So
they don't send it to Africa.
No,
they're expired.
They're expired. Before they actually had expiration dates, that's where a lot of it ended up going, because they would just go back, they get credit for it and send it to another country because there's no expiration date on it. Now, because most drugs have an expiration date on it, that's kind of come to a halt. But back in the day, that's exactly what happened. A lot of it. But,
all right. So a couple of slides on consequences of white bagging. So when the drug gets delivered to the doctor's office, creates a lot of operational challenges for them, and they don't get compensated for all that effort. So they have to receive the drug, they have to store the drug, coordinate with the patient visit. If the patient doesn't show up, the drug is still sitting in their office or in the clinic. They have to prepare, they have to redispense medication if it is wasted. This is what we dealt with in the clinic, and conduct the drug monitoring. So better than I can say, this pharmacist, Rita Shane, she said it beautifully. She said, imagine a restaurant where everyone with a reservation has sent bags and boxes of raw food and ingredients from numerous vendors for the restaurant staff to prepare and cook for each specific client. That's what doctors' offices are doing right now. They're getting all these deliveries, and in my clinic, at least for each delivery, it'll take them half an hour to 45 minutes to coordinate the delivery so that it comes almost at the same time when the visit is planned. And of course, if the patient doesn't show up, it will be more wastage. This was a survey published in 2021 on white and brown bagging from Vizient. So they did a survey and 260 pharmacy providers responded. These are the top issues they responded. 83% product did not arrive on time. 66% people received, but it was incorrect. They no longer needed the medicine. That's another waste. 42% product delivered an inappropriate or wrong dose. 43% product not built in the computer system, so they have to put that NDC number or whatever to make it compatible with their system. 37% product delivered was damaged. 95% experienced operational and safety issues. This is my last slide. Based on the news we have been hearing for the last 2 years. So whether it is FedEx or UPS or FedUp Express, whatever that is, they don't have heated trucks. So these are the real pictures from mainstream media and social media, UPS drivers showing their thermometers. 116 degrees, 150 degrees, 121, 117. In the pharmacy school, we were told, no, you cannot do that. 86 degrees was the maximum temperature which pharmacy can afford. So the whole chain of custody is damaged. A pharmacy is giving it to mailman or the courier company, and they have no idea how to store these drugs, how to carry these drugs. Destruction of a lot of these medications. So, and then when they are delivered, they're left at the porch, at the front door, or in the metal mailboxes. All over the country, we know it's getting hotter. So what's happening to the drugs? So either the drugs are becoming subpotent, they're not effective anymore, or chemically they're getting converted into something more harmful. Those damaged drugs are possibly causing more sickness for people and increase in healthcare cost. And I'm not talking about just the cold chain. So when cold chain fails, of course, the patient will call the PBM and they will reship the drug, right? Another layer of wastage, but it's happening for not just cold chain drugs, but every possible drug out there. Another point is when we are actually sending the drugs by mail, we are sending the New Hampshire healthcare dollars to these mail order pharmacies, which are not even in the state. So the Medicaid, for example, is paying for the drugs, right? It's New Hampshire healthcare dollars. They're being diverted out to Massachusetts or Arizona or Florida. They're coming from those mail order pharmacies from outside. And I think that's all I have. If you guys have any questions, take those. Otherwise, we'll continue with this for another category of medications.
All right, Jay, I'm going to have to ask you for your help to advance the slides, because
Oh, yes, sir.
Impressive. List of problems. Solutions. Is this the next?
Yeah.
Okay.
So one of the solutions is we should stop mandating the mail order. Patients should have a choice. If they live in Arizona or they live their summertime, I should have a choice to say, I am not going to go to your mandated pharmacy as a consumer, as a payer. And unfortunately, these companies call themselves payer. They literally take everybody's money, take from one pocket, put it in another pocket to their own pharmacy, and then they call themselves payer. That's ironical, really. So what I'm saying is it should not be mandated. And then Mark has some amazing solution for this problem as well.
Yeah, so my name is Mark Steltz. I'm a pharmacist by trade. I'm an entrepreneur from Pennsylvania, and one of the companies that that I own and that we're developing, and we've been developing, but it's a long haul because it's a interesting process. Go back one, Jay. We're in Avondale, Pennsylvania. We've been in business for 10 years, and really we have a narrow focus. We do asthma and long-acting reversible contraception, right? And we do it at the point of care. We concentrate on, access for patients, adherence, and medical waste reduction. But the key thing is we work in really underserved populations. We work with Medicaid programs, fee-for-service Medicaid, advocacy groups to increase accessibility for certain medications. And flip the slide, Jay. So that's the slide. So LARCs is their long-acting reversible contraception, but I want you to keep this in mind as a metaphor for any physician-administered drugs. I heard you guys talking about Remicade. I heard you talking about biologicals, and kind of keep that in mind as we're talking through this. Like, there's 5 IUDs in the LARC like in the LARC class, and there's one, subdermal that you put under the skin. It's made by Organon, which used to be Merck, and they're all administered in the physician's office. They range from $800 to like $1,200, and they last for 3 to 10 years. So they're a great, resource for birth control in any aspect of life, any stage of life, and really, accessibility barriers have really made it hard for these products to really get out there, and the downstream effects of like how they're currently delivered, it really causes a ton of waste. And let's go to the next slide. So really, when you have a physician administered drug, there's really 2 pathways, and keep this in mind for your other drugs that you were talking about. The first, the physician has to buy them, right? And then they have to, bill them. And then billing isn't guaranteed. Getting paid for a medication isn't guaranteed. And this process takes 45 to 60 days. In Medicaid programs, it's actually a little more difficult. Fee-for-service is historically hard to bill. Patients go in and out of Medicaid programs. And if there's more than one Medicaid MCO in the state, they can switch around. So the provider can be billing the wrong Medicaid program, Medicaid MCO. And what this does is, the physician doesn't get paid on maybe 1 in 6 of these, and they're $1,000, some of these products. So they quietly stop offering it to the underserved population. So that pathway kind of fades away for the Medicaid population. You're going to find out, if you go around the state, you're going to find very few practices offering high, like effective drugs, being administered from the doctor's office for Medicaid populations. Now, specialty pharmacy, that creates, like Jay was stressing, it creates another issue. That they deliver to the doctor's office. There's documentation, and there's clear studies attached to this presentation that show that 55% of the time the patient doesn't return to the office to get the product. They could be delivered to the home or the office, and they don't come back. So what happens, either the patient gets pregnant or the drug just gets wasted. And this creates that abandonment rate. Jay, flip. So this is pictures from Tennessee. When we started up the program in Tennessee, we actually have 40 cabinets out in Tennessee now. And when our people and our constituents walked into the practices, this is what they see. In each and every one of these practices, they see a pile up of wasted products, and you can just tally it up by counting them. They're all about $800 to $1,200, so they're $1,000 each, and this exists in every darn practice. This doesn't even include the ones that were shipped to the home and didn't even come back to the office. So let's jump to the next slide. So imagine this is just one segment. We're not talking about biologicals. We're talking about one market class, a small one, long-acting reversible contraception. It's a $1.7 billion market in the United States. 55% of them that are sent to the homes to the offices are wasted because the patients don't come back. And 21% are covered by Medicaid in the United States. So that's a $200 million waste that is happening on very simple, straightforward math. And once a device is abandoned, to Jay's point, because it was dispensed through a pharmacy, it cannot be reused for another patient. That's the federal law. That's just the way it works. So the devices have to be destroyed. And as a side note, Medicaid is paying for 41% of the births United States. So the fact of the matter is that's why that the LARC program is dear to our hearts, because we're very aggressive about getting the program out there. Let's move on to the next slide. So when you look at the whole health system and you're using LARCs as the example, there's a huge amount of financial loss. First, if the drugs aren't delivered, they're not given at the point of care. The payers lose money because of the waste. The whole health system loses money in the LARC program because, in not administering a LARC program, because healthcare pays for unplanned pregnancy. So it's pretty remarkable. Payers and providers quietly walk away from the programs because the products they're not getting reimbursed consistently when they bill for it themselves. In the state, tend to, in a lot of states that we work in, they eliminated the mail order, process. The problem if accessibility isn't there on planned pregnancy is higher. There's an increase in maternal morbidity and mortality. There's an increase in health disparities, meaning the products that you can give out of a doctor's office, if they're not used, they tend to not be offered anymore. And the lower the vulnerable populations, lower income populations, are the ones that suffer more. Like commercial insurance is historically easier to bill, and women in our case, in our example, lose access to a highly effective contraceptive. Let's jump to the next slide. I'm moving along quickly so we have time to talk about this at the end. We maintain the solution is we put products at the point of care. We put the long-acting reversible contraceptive at the point of care. And really, there's this whole study that says, well, if you get it when the patient walks in the door and you can dispense it to them right there, then it'll cost $2,000. But if you dispense it, you got to wait for them to come back. When the mail order pharmacy delivers it to the doctor's office and they have to come back, the waste adds up. It costs the program an average of $4,000. This includes not only the abandonment, but the unplanned pregnancy that your Medicaid programs are paying for. So it's an impact on all of the healthcare system. Let's move on to the next slide. So in response to this, we built a point of care access cabinet. And do you want to jump back one, Jay? And what it does is we first looking at existing products like Omnicare and Pyxis, and they were just so expensive. They were like 30 grand a pop to put on site, which was cost prohibitive for a mass rollout. So what we did is we built our own. We started creating them. We hired our programming team. We started, betting the metal in Pennsylvania, near Bethlehem, and creating our own cabinets and putting them together. So we were able to create the smaller ones for $1,000. You know what I mean? It's immensely less than what it costs to buy a product, and then we could put them into doctors' offices free of charge. We would, and then put products at the point of care. And they're very intelligent cabinets. They track inventory, they track dispensing, they track everything down to the serial number, they track temperature, they track humidity. They track. We process the claim on our side. It comes across the cabinet in a queue. We know what's paid for. The doctor selected. They have a pharmacist overlooking it. So there's a drug utilization review that happens. And so I mean, if the patients are on other drugs that conflict with the drug that that is being inserted, in this case, it's the LARC products. And then we restock the cabinets and ship out to the cabinets. So by putting the products at the point of care, you reduce the fact that you only dispense the product when the patient is there. You're not sending a product in there that can't be used again. The patient is there. So it works for anything that is at the point of care. A patient arrives, you have LARCs in the cabinet, they're inserted and done right there. There's no waste at all. We have zero waste in Tennessee, and we dispense a lot of products. And the fact of the matter is we're in 5 different states now and growing pretty rapidly. It takes a while for, just other states to talk about the success of the program. And so we're able to grow a lot quicker these days. But this also works for other products that are delivered at the point of care. If you're worried about the waste of a biological or the waste of like Remicade, if it's administered in the office and it had to be white bagged or brown bagged to be brought in there. Everything is controlled at the point of care and dispensed at the point of care. So you reduce waste to absolute zero. So that's us in the nutshell.
Impressive. Thank you very much. What are the problems in rolling that out for Sublocade, or one of the drugs that we've talked about for which there's a lot of waste?
I mean, say that again. I couldn't hear the first part of that. Sorry about that.
That was all. Thank yous. What are the problems in rolling out your cabinets for drugs for which Jay has documented a substantial waste?
Yeah, so what it is, you actually first have to get it approved by the state board. And dispensing at the point of care was something that was always protected by the boards of pharmacy, because they don't want, people going out and dispensing products that, at the point of care, because it competes with, all the retail pharmacies. But if you keep in mind that these are drugs that are only dealt with by specialty pharmacy and by, companies like us. I mean, they're point of care, they're physician administered drugs. They don't affect the normal retail offerings where you walk into a store, you walk out with your pills or your inhalers and things like that. These are products that are administered in the office those are the products that you can truly affect well. And really you work with the state board. We did it in New Mexico, Tennessee, Delaware, a bunch of states to just, create guidelines and a scope, and then we roll out and we make sure that we have full approval, because you want it. There's so many challenges, because, like for it to work properly and to be part of a Medicare program, it has to be under the auspices of pharmacy, because you can't be billing on the pharmacy benefit at a different location under Medicaid than what you're dispensing at. So it's part of the, CMS rules, you know what I mean? You'll be breaking the law, you know what I mean? So it has to be under the auspices of a pharmacy at a different, in the cabinets are essentially our pharmacy. You can dispense at the point of care then, you know what I mean? Under the pharmacy benefit. It creates and it's nice to be dispensing under the pharmacy benefit, because we can tell that it gets paid right away. You know what I mean? And you get reimbursement right away through the electronic transmission, and the medical side of the billing doesn't work for that. Why that's handy is that, we know the patients there, we know the patients on the program, it gets reimbursed, it gets dispensed, and everybody's happy. It creates a closed loop process, and it creates a lot of reporting right back to the Medicaid organizations, because they get the data almost instantly, and they can judge it, look at it, create their own outcomes from it.
So just to add to what Mark said, in our clinic in Harbor Homes, we were able to reduce the waste to almost zero, thanks to our Medicaid pharmacy administrator, who's sitting right behind me. So I reached out to her, and she helped me negotiate those contracts with the PBMs, who were not happy, but they did it eventually anyway. So now the procedure is, when the patient checks in and is ready for the doctor's visit, that's when a nurse comes to the pharmacy and picks up the prescription. We don't sell these products to the patients anymore. So we are able to reduce it to zero, but there are a lot of clinics out there who could utilize services what Mark is offering.
Yeah, it's nice that Jay's pharmacy is on the site of the clinics, because that's truly powerful. But we're in all throughout rural part of the U.S. where there, healthcare access is tough. So we're putting, access in places that it really doesn't exist, and that's really our whole mission and our vision, just create accessibility, do something that's impactful, and make sure that, the systems work and they're running error free.
The United States has a fairly well-developed system of federally qualified community health centers. It sounds, from my knowledge, are you one? Is the Harbor Homes a community health center? So to what extent are other community health centers able to act sort of, with regulations and laws make it possible and actually have accessed these products, the cabinets, let me call them the cabinets.
That's a tremendous question. In New Mexico, all we do is work in federally qualified health centers. We work in school-based and the primary ones that are stretched out. And it makes it better for the federally qualified center because our products are outside the encounter, the visit that they're allowed to charge for. So it helps them with accessibility, and we get the approval at the state level for that. The state, they have to look at how they, I guess, charted it on the state level, and New Mexico gave us approval to work that way. And in Pennsylvania, we work that way too. We were in a few federally qualified health centers. Tennessee, we're in our first few. They're just working through the minutia of it. So we're walking through that right now, that process.
So I don't have the study before me, but came across a couple of studies that the estimate is between 3 to 5% of drug costs in this country are contributed to drug waste, either because of the physician's office not consumed by the patient for whatever reason. So if you think about a $500 billion industry, you take 3 to 5% of it, we're talking about some real dollars. The question is, how can you somehow get that percentage down to as close to zero as possible? If you have the pharmacy like you do with Jay's place, then you have the dispensing capabilities right there. But when you have a physician's office that doesn't have the size to accommodate a pharmacy, then it becomes a problem. I can share with you from my own experience at the medical center when we had Remicade, and it was back the same thing. And I'm trying to say pro or con with it, but when we had product that come into the pharmacy from an outside pharmacy, normally from a specialty pharmacy, it has on the product the patient's name on it. So we'd come in, we put it in a refrigerator with the intent to use it on the patient, which we do. However, many times the patient would fail the therapy. There'd be changes, or the patient would demise, would pass away. Because of that product having been shipped into the pharmacy from outside, we had no choice. We called the manufacturer and said, would you take it back? They don't want it back. We called the pharmacy, can you take it back? Now state law says, or federal law says, we can't take it back. So when I start looking at the overall cost of the product, and you look at the waste associated with it, it starts to add up. So it sounds great on paper because you can reduce the cost. The difference between a specialty pharmacy sending it into a clinic versus at the retail level. In a community pharmacy, if you fill the prescription, but it never gets to the patient, right? You can put it back in the inventory. Once it leaves the pharmacy, you can't put it back in the inventory. So therefore, the waste incurs because the pharmacist has no way to return unused medication back into an inventory because it's outside of their control. So that's part of the issue going on, is that it sounds great on the front end because you can get the acquisition cost, if you will, lower, but the overall cost of the waste that gets built into it makes the overall process sometimes more expensive.
Just to add to what Gary said, most of the drugs we are selling now are moving towards those expensive specialty drugs.
Yes.
So more than 50% of expenses of those drugs. So it's the waste will continue to rise.
Yeah, and I'm convinced about one. When you look for waste, if you look for waste on physician-administered drugs done by white bagging, that data does not exist. I mean, it really doesn't. You can look everywhere for it, and there's nothing accurate out there. And think about I mean, there's all these MCOs out there that like we were talking, like nobody wants to publicize it. Let's face it. Like if you're shipping stuff to the patient home and it's, you know, there's an MCO that isn't, you know, that knows the waste exists, they're not going to say, well, we're creating waste in our programs. It just, nobody's going to sit there and advertise that. And it's, you know, counterproductive if they own if they actually own the specialty pharmacy and the PBM. It's kind of crazy.
So the question for in the database, is there a way to flag a drug that was billed to Medicaid but never administered to the patient?
I don't think in the claims data that exists.
But would you be able to, per se, would come out and say that? But what I'm trying to get to, if you got a charge for the drug but no charge for the administration of the drug, would that not be a red flag?
Yeah, I mean, that would require inferential modeling.
Yeah.
To look across the continuum of occurrences, and if it was sufficiently powered, you could maybe look at that. Yeah.
Be something that, you know, the data analyst, I guess.
The first step is to identify what's going on with the difference between the Remicade billing and the medical benefit to the pharmacy, and then to see drilling down to the next level of granularity if available data can support that. A lot of the medications delivered at hospitals, there's an indicator variable, hospital or outpatient. And that might be the parameter of interest to stratify that by.
So if I understand, I think I followed you. So if we go back, because if it's being shipped to the clinic by a specialty pharmacy, most likely it's billed into the PBM side. I assume it's probably why I have the NC number there versus it being a J code.
Yeah.
So
you have titled that analysis the brown bagging analysis, or the white bagging analysis, not the buy and bill. Yeah.
So therefore, instead of the clinic buying the product, they're getting it shipped to them by a specialty pharmacy, some pharmacy. So there's got to be a claim in there for that payment. The question at that point in time is that you probably have a patient identifier somewhere within the database. So you could go back and look and say, okay, drug was paid for on August 10th, whatever. And this is the patient identifier. There should be somewhere along the way another charge for the administration of the drug.
So there's professional fees and facility fees, and those usually come with, you know, those are some of the ancillary services billed with delivery of medications. Whether or not those are different across the two, I've not looked at that, but it would be interesting to look in each of those sequelae of claims to see how that fleshes out.
Yeah.
And that could be some sort of proxy. How reliable, I think, may be a matter of debate, but some sort of proxy for waste of specialty drugs.
It's just be interesting, you know. Mr. Stell, is that kind of, do you know anything as far as any way to look at the databases? Have you come across any data saying this is what's been shipped in, but this is not what was utilized outside of?
I know it's really merging the medical claims with the drug claims, and we do that with 10Care, but it was an arduous process to get started. It really truly was, and we're just looking at one specific class of drug, you know, in a program that they're in. But it was, you know, because they were really pushing the program, and they kind of incentivized the doctors to kind of in their own way to get involved with the program, the ones that, you know, got involved. So they were aggressively looking at the claims up front. It was hard to get back to the retrospective data, but the current data is very clean. So
was there a model that you built with 10Care?
That's their proprietary side. That's kind of it's hard to get insurance companies to give up their info, but I know they're doing it.
Okay. All right.
So question, I'm trying to think of it. Let me characterize what you're selling as the stellar cabinets.
Yeah, we call them X-Spino's cabinets, yeah.
What you're basically doing is distributing a alternative to specialty pharmacists.
Yeah, that's exactly, it's another distribution channel, another distribution chain. It's just
the people who will push back will be the specialty pharmacists, impede your getting through the state process.
Yeah.
And pharma, the industry itself, because what we're calling waste here is basically profits.
It's funny. We work with three manufacturers. We work with three manufacturers really close. We work with Organon, that used to be Merck. We work with Bayer, and we work with Cooper Surgical. Bayer is a strong proponent. They're all for it, right? Organon was at first, and I figured out that I think they figured out the effect. They figured out the waste is going away, and they kind of pulled back. They're still supportive. We're a small company with a direct purchasing contract with them. They give us that, but they're not aggressively pursuing our growth like Bayer and Cooper Surgical. They make one of the products. So yeah, some pharmaceutical companies see the light. They understand that that when people discover the waste, they're going to be angry. You know what I mean? And so they're kind of like going, oh, good, a new distribution channel, and some kind of run from it a little bit. So I think you're going to find both sides of the street there.
So, Mark, so is there in your experience and so forth, and traveling to different states and so forth, like I talked about before, if I have this product here and it has a patient's label on it, and it's still in my pharmacy, then I can put it back in my inventory. It never gets charged. It gets charged, but the charge gets reversed, so no one's paying for it.
Yeah.
Is there any movement going on saying to a specialty pharmacy that if you send it to the clinic, if you will, that if it doesn't get administered to the patient, they can send it back to the pharmacy and
No, that's like I've heard that argued. Even our program, right? Well, when it comes out of the cabinet, right? And the patient's right there. There's maybe 1 in 100 times the patient will, not want the product when they get to the room, and it's in the possession of the practitioner. We have the approval to put it back into the cabinet because it hasn't left, the possession of the practitioner, and the outer cellophane can't be removed, and the box has to be intact, and we have to get a picture of it and document it, and we're allowed to put it back in the cabinet in Tennessee. And that's kind of like, and they were really protective on that process, and I can't even imagine what they would do with something that's not temperature controlled, out of the because it's more than just being out of a common carrier. Most state law makes it's been handed off from the common carrier to the doctor's office, so it's one more step in the chain of custody, and that doctor's office isn't recognized as part of that chain of custody for a medication leaving a pharmacy. So in all states, it's been a no so far. I mean, which it's more federal law, right? Jay, what's your thoughts on that one?
I'm not sure.
I'm just trying to think of if the waste is getting created, who can somehow take that waste out of the system, either by minimizing the waste or saying, okay, if it occurs that you at that point in time hold the person paying the bill, they get a refund because it was never utilized by the patient. I'm not trying to solve it today, but again, looking for solutions.
Yeah, and it's challenging. Like on a retail store, there's always a signature log, or there's always documentation that it was dispensed. But when you're working with a specialty pharmacy and mail order pharmacy, it's different. They mailed it. They have a proof of receipt, and that's it. So that it's been dropped off. There's no regard to whether the patient actually is able to use it. So it's kind of like an interesting dilemma.
All right. Is there any questions? Senator Rosenwald, I see you on the Zoom. Do you have any questions for these two gentlemen?
I don't. I'm sorry. I'm trying to follow, but it was hard because I missed the beginning.
Thank you. Yeah. Is there any questions from people in the audience before I leave?
No, Funstein had his hand up
Who?
at some point. Funstein. Had his
Oh.
hand up at some point.
Who else is?
Me too.
Yeah. Mr. Funstein?
Oh, thank you, Mr. Chairman. No, actually, it was just a comment. I want to say that if I ever want to produce an infomercial, I'll be sure to ask you for the contact information for Mr. Stelz. I thought that was a great commercial.
All right.
The only thing that disappointed me was I fully expected to hear about your plans to franchise your product. But I'll stay tuned and follow you online, I guess.
Yeah. I mean, it's sound. We make it sound easier than it is because you got to get approved at the state level with each state board and move it through the process. But we're committed to it. So,
Thank you. Anything else? No. With that, then I'll close the presentation. I want to say thank you to both of you for an insightful presentation and helping us understand what the downside is of having drug waste and finding possible solutions and having and coming to the table, not just talking about the problem and talk about a potential solution, because a lot of times all we hear about is the problems. We never hear about any potential solutions to it. So I want to say thank you.
all right. Well, thank you for having us. Thank you very much.
Also, in regards to legislative updates, legislation, there are two retained bills in the House Commerce Committee. One was to for the board itself to be repealed. Another one to do redundancy. My understanding of both of those bills most likely are going to die in the committee. Given the fact with HB2, they funded the committee out of general funds, and at the same time, there is an issue in HB2 about redundancy, and that brings me up to Dr. Ez's to talk about the redundancy. I think in HB2, there was a language in the bill to look at redundancy between this board and specifically the insurance department. So did you want to make any comments about that? It's not due until October 1st of 2024, so we still have time. But I think as the liaison between this board and Department of Insurance, could you give us kind of an update? What are your thoughts on how to walk down this road of looking at redundancy report?
Thank you, Mr. Chair. I think so in reading House Bill 2, it was quite specific on which areas of redundancy the report should contain, and so I took on I created an outline that pretty much took on a topical format where laying out redundancies in terms of data reporting from entities, and so stratifying that by entities, including drug manufacturers and PBMs and insurance carriers. So there are a few state laws that exist. One between the pharmacy, there's a pharmacy board law that requires the insurance department to collect data on new high-cost prescription drugs. And that's an example of a data reporting redundancy that's also under the authority of this board. And so that's an example of a topical one. We also at the insurance department collect licensing fees, licensing information, and total drug spend and rebate information from PBMs through some other authority, RSA 402N. And so I've listed these topics in an outline format so that we can lay the framework for this redundancy report that frankly will probably be shorter than I initially thought. And so, because I think House Bill 2 has a much more narrower directive than did the bill that preceded it.
Correct. Okay. In your opinion, is that something that we probably get through the annual report, because that has to be due by the 1st of November, and then possibly taking some time starting in November thereafter to talk about how to proceed with this redundancy report, or is it something, how can we help yourself? How do we help, if you will, on creating the report? How do we create the collaboration between this board and the insurance department? So would that be a good time, probably in November, to start talking about that nuance?
Yeah, I've spoken with our acting commissioner, Betancourt, about that.
Yeah.
He suggested that we consider maybe even an interim report and not wait till next October of 2024. A lot of time and a lot of change will transpire. So I think I'd be prepared for our next meeting in September, not October, to have a first draft for all board members to review and offer feedback on you know, not just the redundancies, but you know, where the divisions of authority lie, in the interest of having a much more clear approach to that.
I think trying to do something makes sense, but I think right now, because in September we have another person coming to talk about this board dealing with market adoption of biosimilars and trying to find out how we can encourage people to make the transition from the brand name, which is not really generic, but to a similar biosimilar, to reduce the overall cost. And then in October, we're going to have probably healthy discussion also in September about the annual report, and be sure we have hit as much as possible what the board members want to see in that annual report. And then the final one will be in October to finalize that draft in order to get it to print by the 1st of November, which would be the following day. So could we do it sometime in November?
Yes.
Okay.
Representative Edwards.
Who? Oh, Edwards. Roosevelt.
Okay.
Senator Roosevelt.
I have to let him. I have to allow him to do it.
Who's it?
Jess Edwards.
Yep. What?
Jess Edwards. Representative Edwards, you wanted to talk?
I do. Can you hear me?
Again.
Okay, so I don't know how HB2 got reduced down to looking at redundancy simply between the PDAB and the insurance department. In testimony, there was discussion about how redundancy also existed with the program being run by the administrative services. I forget exactly what it was called, reverse auction, something like that. And that was always intended to be included as part of the redundancy review. And then at the federal government level, they are supposed to be doing a lot of this stuff as well. And so if we were to operate in good faith and do a redundancy review, we would look at all of the players in this space and not an artificially constrained one-to-one comparison between the PDAB and the insurance department. And I know what the HB2 says, but I don't believe that this board is constrained or limited to that. I would say that that would be the minimal essential comparison, but I don't think that's the good faith comparison. It doesn't answer the mail of what caused the redundancy question in the first place.
Thank you, Representative Edwards. I think at this point in time, when Dr. Ezis does the presentation in November, that may be something to talk about, is what are some of the other things we should be thinking about beyond what's in HB2? And I think at that point in time is saying to Representative Edwards' concern is that we don't keep it narrow. There's nothing that says we can't expand it, but we should be thinking about it at that point in time. So could you be thinking about that when you talk about this in November?
I will, yeah.
If you don't mind. Thank you.
So I would actually ask the insurance department to do that now. Don't let this report get out half-assed. Do it right.
Well, I think we're going to have a conversation about this in November. If I understand correctly, in HB2, this report's not due until October 1 of 2024. Is that correct? President Edwards?
I don't know who you're talking to there, so.
I'm talking to you specifically on HB2. My understanding is that report is due on October 1st, 2024.
That sounds right. I don't have it in front of me.
So I think your point's well made. That we should do this logically, systematically, and not try to rush it through in 2 months. I think we should be sure that we take our time and be sure we have a well thought through report and not have something that's, as you call it, half baked.
Sure. One last comment, and then you can turn off my mic. This is not a surprise. The department has known about this since January, the concerns about redundancy. And so it isn't as though they would be starting this redundancy review from scratch. I think they've done some interim comparisons already. So I just think getting the right answer the first time is the best solution. But that's just my recommendation.
Thank you for that. Yeah, thank you. I just want to be sure whatever we do it right and not do it quick. I'd rather have it done correctly, and even takes a little more time than to rush through it and have something that's, half baked and have it come back. Future meetings, we have one, I think, at the end of September.
American flag bar.
September 24th, I had.
24th is what I have, correct?
25th.
Hold on, here's September, hold on, the 25th.
Right.
And that's from 10 until noon.
Yeah.
And then we have another one on October 30th. Again, from 10 to noon. And Ms. Bird, is this room reserved for those?
Yes.
Thank you. And then as far as that goes, I'm looking at the calendar in November. There's the 27th, a little bit too, I won't be here. So we could do it possibly in November 20th. There's a possibility on Monday, or we could do it in December. I could do it probably on December 18th before,
I could 20th of November.
I think Senator
Roosevelt. I think.
Yes, I believe that September 25th might be Yom Kippur.
September 25th.
I think you'd have to check when it ends, but
yes,
it is.
24th is young. I have the 25th, not the 25th, but I don't know that.
Starts on the 24th in the evening, I think. And
goes
till sundown on the 25th. So I don't think it's an appropriate day to have a meeting.
Correct. How about the following day on September 26th, Central as well?
What day of the week is that?
The Tuesday.
I know, but
yeah, I mean, that looks clear at this point. I just don't think we should have meetings on the Jewish high holidays.
Right. I concur. Is September 26th, what are you gonna?
I'm gonna have someone sit in for me. I'm gonna have it down.
How about the 28th of September? There you go. What do you think?
Clear at this point.
Yeah,
There you go.
No, it's just one day.
28th could work. What about the 28th, Bob?
I've got a conflict, but I can probably schedule around it.
We could do something in the afternoon on the 27th.
Yeah, the 27th and 28th are
Problematic.
Problematic.
So is it,
But either one.
is 26 better than?
26 is better.
Okay.
Uh,
Senator Rosenwald, is 26 work on a Tuesday? That's a
As
day
far
after
as I know at this point.
we try to see if we get the room here. 26.
Okay.
Oh, it's thinking. Okay. Oh, I see the wheel.
Yeah.
Oh, yeah.
The wheels are turning.
The wheels are turning. Jason, does that work for you?
Yeah, that one.
It is booked all day.
All day.
Indeed.
Okay.
Did you say no to the 28th?
20. Well, Dr. Woodward hasn't.
I put it back to the 28th, and I'll just see if I can schedule somebody to.
Wow.
28. That's fine too. What was I thinking?
It
28 is fine.
looks
Yeah.
like she has it for a few days.
Nancy, what about 468?
We could. The only issue with that is that it's a public meeting, so.
Yeah, but that's fine. I've been having my DOR board meetings there because.
How do you let people?
They wait in the lobby and I get called down to him to score them up.
Okay, I can do that.
Yeah. Okay.
There's a limit to the room though. 468 was 18.
Oh, that's fine.
Something like that.
But this group, I'm gonna move that.
Okay.
So 26 was back to.
I will find a room. Whatever works for you guys, I'll figure it out.
So
I'd have to add the
26,
room.
Bob, 26 is better for you, correct?
It is.
Okay, is that gonna work? Good. Well, Senator Rosenwald, right now, 26th of September works?
Right now it does.
Okay. All right. September 26th it is. What's it? 26th, hold on. Do I have anything going on? Oh, hold on. Well, another committee meeting. Committee. Let me get executive. I think I have a. Sixth of can't do the 26th. I can do it in the afternoon, but I can't do it in the morning.
Fine answer. I'm fine in the afternoon.
So is that okay from like, tell you what, 1 to 3? On the 26th, that work?
I'll be there.
You'll be here. Okay. All right. Public comments outside of Feinstein. Fancy behind. Oh, Mr. Barrett, yes.
Thank you.
Yeah.
Again, I'm Curtis Barry here representing PCMA, which is the National Trade Association for the PBM industry. Wanted to make some very brief comments on the presentation and not specifically to the Harbor Care experience, you know, but on the white bagging generally and not specific to any one individual product. First of all, I think there in the white bagging issue, the presentation that you were given, there are a lot of holes, a lot of questions and a lot of pieces of information that are missing. No offense to the presenter. I hope that you all would be willing to listen to some responses at some point in time, comprehensive, if Ms. Kroll was amenable to jointly presenting something from our perspective. But I'd like to make 3 or 4 very brief points. First of all, on, I think it was the third slide, you were given some data on the National Drug Take Back Day. And you were given some supposition on waste from white bagging. And you were asked to draw a line. And then we were asked to raise your hand if you contributed or participated in Drug Take Back Day. I have. I've contributed oxycodone that I didn't need anymore. I felt I didn't need anymore. And I hope the implication is that I should continue and take the rest of that prescription just because it's there. That's not the case. My point is, though, there's one piece of data and another piece of data, but you don't know one subtracted from the other, right? There's the assertion that white bagging is without compensation to those administering the drugs. That's not true. The administration in that piece is built under the medical plan, right? On the same slide, this is slide number 4, there was which I can appreciate the analogy to the restaurant business. I grew up in the restaurant business, decided it wasn't for me, and left at an early age. But the piece of information that's missing there is who's paying the bill. You all are charged at looking after the pay. This analogy is direct and on point if it says that the state of New Hampshire is paying the bill. And if you're faced with a choice that the restaurant charges you multiple times more for the ingredients than if the customer brings the ingredients themselves, in which case are you responsible for it? Are you better off, right? Which leads to, I think overall, why does white bagging exist? I think if you're gonna look into this issue, you should look into how much under buy and bill. I think we started to get into that. You folks started to get that a little bit. Compare how much is being charged for the medication under buy and bill versus white bagging, if you want to get into that issue. But again, I hope for an opportunity for a more comprehensive response on the subject of white bagging. The bagging is willing to do. Thank you.
Good afternoon, Mr. Chairman, members of the committee or board. My name is Heidi Cole and I represent America's Health Insurance Plans. And I would echo what Curtis had said. We have, representing the carriers, we have a different perspective on the white bagging and brown bagging issue. Our hope always and our goals are to make drugs as affordable as possible for the members of the carriers and the businesses and the citizens of New Hampshire. And we also certainly want to reduce waste. We recognize that there are costs associated with that. To the point of white bagging and brown bagging, the reason that white bagging and brown bagging came to be was a market response to really the outrageous pricing that was happening under the buy and bill model. Some would call it price gouging, and there have been studies, multiple studies around this issue. A 2018 study by the Moran Company found that on average, and I'm quoting here, on average, hospitals charged 479% of their costs for drugs nationwide. The study goes on to report, and I quote again, those hospitals, 83% charge patients and insurers more than double their acquisition costs for medicine, marking up the medicines 200% or more. Majority of hospitals, 53%, mark up medicines between 200 and 4% on average. A small share of hospitals, 1 in 6, 17%, charge 7 times the price of the medicine, and 1 out of every 12 hospitals, or 8%, has an average charge markups greater than 1,000%. So carriers are supportive of any and all delivery options that are bringing competition into that equation and to bring the prices down. We have not seen kind of safety and waste issues that were brought up today. And so we have a different perspective, and we'd be happy to present in collaboration with Curtis on kind of our perspectives and again, keeping the payer in mind. And obviously this is focused on state payers and looking at Medicaid and what the state is paying for its state employees. But there's certainly, I think, an indication that the state is also probably using white bagging and brown bagging for the state employee health plan. And there's a reason why carriers, commercial carriers, and public payers and self-funded payers are all looking to these types of alternatives.
Thank you. I'd be interested to learn more about it, because if the insurance company and so forth looking to reduce their costs, which I think is phenomenal, because all it comes back to the state itself. But given that, is there any way that the insurance companies then, if the patient doesn't use the medication, they'll reimburse the state for not using? If the goal is to get the cost down, and that's what we're trying to get to, but part of that cost is still going to be drug waste, is a way to then hold the state not accountable because the patient didn't show up.
Hold the state harmless. That's the
Hold harmless. Because at the end of the day, I think that we're both on the same page at that point in time. As long as state's held harmless, that's the point. When the drug doesn't get utilized, regardless of the mechanism of how it's distributed, that would be really interesting to hear more about.
And I don't know much about this. From what I'm understanding, there are definitely federal guidelines around that, and potentially, I guess, the state guidelines as well. But my point is that there's the waste, so there's kind of the quantity, but there's also the price. And so, you know, even if there is, I don't know that there is evidence of this, but if you assume for a moment, or take the hypothesis, I think that was presented, that there's more waste under white bagging than there is under a buy and bill model. If under that buy and bill model, the prices are 400%, 500%, et cetera, higher, you know, that has a balancing effect in the equation of what the ultimate cost is. So I agree that we should bringing down waste. We should also be bringing.
Sure. But it'd be interesting to find from your stakeholders, communities, and so forth, what they're doing to keep the state of the care harmless, hold health harmless, because the drug also doesn't get utilized, and some are still paying for something that doesn't get paid for for use. I'd be curious to find out what's out there, what you folks are coming across to minimize that. Sure. Thank you. Yes.
Hey, can I give a quick vignette?
Yeah.
That when COVID occurred, the lines to get the COVID vaccine were long. In the local area, there was a National Guard unit that was located in Exeter High School, I think, that you could make an appointment for. I was interested in getting the vaccine as quickly as possible, and had the bright idea that if I went in the afternoon, late, that there might be some of this excess that they might be willing to provide me before I had an appointment. I went and was told politely, get lost. We are sending our vaccines to local community health centers where they can get it themselves. One questions whether the community health centers already have access to 340B, which does help a good deal with respect to price, but it doesn't get at the real waste issue.
Yeah.
And the question is, to what extent are states willing to consider doing with some of these very common, perhaps injectables? You can get the vaccine and flu shots at your local pharmacy, not having those named, not having a person's name associated with it, so that it could be shared with community health centers as the expiration dates approach.
That's a good point. I don't know. I know one of the things that's happening in nursing home arena, not to build off the discussion, but it's to minimize the waste, because a lot of nursing homes are sending back patients with expired and so forth, literally cards of medications, and trying to get them, if you will, redistributed because they hadn't actually meant for the patient yet. That fell to the floor because you couldn't have consistency of supply. And when you have a patient all of a sudden going to a pharmacy to have it dispensed to them free of charge, the challenge the pharmacy had was reliable source, because they were coming all over the place. So what some trials are going on is you're now doing the cabinets. So in a hospital, you go to the cabinet and you take out, the nurse takes out the medication they need for that day. Each one is like a little sugar packet. So it's minimizing the waste, because at that point in time, they're only taking out of the cabinet what they actually need. So they're trying to do the studies again, back to the same thing, the cost benefit, saying what's the cost of the cabinet? Is the cost of the cabinet less expensive than it was the waste itself? And that's why I'm trying to work with these folks, saying the same thing, looking at the cost benefit, saying there's a technology, but in some ways hold people accountable. So I think there's many moving parts to it. It's a very complex pharmacy supply chain, a billing process and so forth, but the goal is more to try to figure out how to bring down overall drug cost to the public payers in any way we can. It's not just the cost of the drug, it's a question about rebates, it's a question about drug waste, it's a question about biosimilars. How do we somehow start thinking about strategies that are going to reduce the overall cost to the taxpayer? Any other more comments, Jay? Please.
So I just wanted to respond to comments from PCMA. I'm really surprised that you guys want to hear in this room, because your mission from your website is to increase affordable access to prescription drugs for everyone. If you guys were, and your members were doing a good job, this board would not even exist. This board is here because you guys kind of spend a lot of stories which are not true. So there are a lot of reasons why PBMs make billions of dollars extracting money from healthcare systems. I'm really sorry that you are making counter arguments on the basis of the data I presented, that you don't even have data. Of course, the data will be put up by your members, but you have to take it at the face value. There are people every single day in America who have to choose between their medicine and the food or paying the rent. And PBMs play a very negative role in this whole healthcare system where people cannot afford their medicines. You probably know that PBMs have Swiss accounts now, Ireland accounts. That's why Federal Trade Commission is investigating why American healthcare dollars are being put in the offshore accounts.
Okay. Thank you. I don't want to get into a he said, he said.
I'm not going to respond to this number, although we've presented the data that justifies the existence of PBM. Okay.
So at this point in time, I think we're going to move to adjourn unless there's something else somebody wants to say. Senator Roosevelt, thank you for being here as well. We'll make the meeting in September. Hopefully you can make it as well. Hopefully you'll have a good Yom Kippur. We don't see you until then.
Thank you.
You're welcome. All right. Adjourn. Thank you.